Okay, hello. My name is Allie Alsop. I am the education coordinator for Mercy Hospital Springfield for our respiratory care department. And today we are going to talk about ASV, also known as adaptive support ventilation, and its clinical applications. So, little disclaimer, I do not work for Hamilton Medical. This is a ventilator mode that is exclusive to Hamilton Medical Devices, but I do not work for Hamilton Medical. This video is for educational purposes only. Just another disclaimer, this video is mostly tailored to my current respiratory therapist here at my facility, as well as some of our facility protocols and procedures in relation to ASV. So now we are going to begin to discuss our objectives. So our objectives are define adaptive support ventilation, discuss the clinical applications of ASV, discuss ASV settings and setup on the ventilator, and ABG manipulation and ASV. So before we get into too much detail about ASV, let's kind of go over what the definition is. So adaptive support ventilation, also known as ASV, is a ventilation mode that selects and continuously adapts the patient's respiratory rate, tidal volume, and inspiratory time depending on their lung mechanics and effort. It will automatically employ lung protective strategies to minimize complications from auto-PEEP volume trauma / barrel trauma. It can also prevent apnea, tachypnea, and dead space ventilation. One of the things I do want to point out early as far as how it employs lung protective strategies, one of those strategies is setting a pressure limit. So there is a pressure limit that you can set in this mode to limit that patient's inspiratory pressure. So let's look at ASV versus conventional. So in ASV, there are only 3 parameters to control ventilation as well as oxygenation, and we will go over those 3 parameters a little later on in the presentation. It can be used in active or passive patients. A misconception that I hear often when as a clinician is that we can't use ASV on sedated and paralyzed patients. That is when you can use ASV as a mode in any patient population, whether your patient is awake and alert, whether your patient is completely sedated and paralyzed, or your patient's completely obtunded and non-responsive. You can use this in any patient population in the ICU. Now, looking at it compared to conventional ventilation, the clinician can set the ventilator controls such as tidal volume, pressure, respiratory rate, and expiratory and inspiratory time to achieve the clinical targets, including a certain level of alveolar ventilation and oxygenation for the patient, but it is very dependent on the patient's activity. So you have different ventilator modes that you can select depending on what the needs are for the patient. You have the option of setting a pressure control mode. You have the option of setting a volume control, pressure regulated volume control combo mode. Or if your patient is awake and alert, you have the option of placing them on spontaneous or a CPAP pressure support mode. So, big thing we also hear about, how do we have control over the patient's ventilation? And this was several reactions that I had gotten from physicians when we first introduced ASV at one of our hospitals when I was a respiratory student in San Diego, was where's my tidal volume control, where's my respiratory rate control? Well, you're not controlling that. The patient's actually controlling it. We are setting a goal for them to reach in order so they can tailor their own pattern of ventilation, pattern of breathing towards that goal. So conventional ventilation modes, we set them manually, and we need continuous assessment by that bedside clinician as to how that mode is working for that patient. ASV automates this process, giving patients more control over their volume and rate. And a little bit later on, we're going to do some simulations using the C6 simulator, and I'm going to kind of go over how it continuously will adapt to the patient, where we're not having to change respiratory rate or tidal volume continuously assessing the patient. It does it automatically. So looking at ASV versus conventional modes as far as the ventilator controls go. So on the left you see conventional ventilation, so you have the option of selecting pressure control modes, SI and V, spontaneous, and we have different controls here such as our pressure control, pressure support, I time, tidal volume, respiratory rate, IE ratio, and then you have your oxygenation controls, which are your PEEP and your FiO2 setting. Looking at ASV, it's very simplified down. It is only 3 controls. Here we are setting the percentage of the minute volume of that patient, and I'm going to go over how we actually get that setting here in just a second. So this is where CO2 elimination and ventilation and patient support is controlled. But as you can see, it's only a percentage setting, so I'm going to go over how that percentage setting actually applies to the patient's target and goal. And then you also have the option of setting your oxygenation controls, which of course are your PEEP and your FiO2 settings. Let's use my arrows next time. So how the heck does this work? So the clinician will set the target minute volume, and the ventilator determines the combination of tolerable rate and respiratory rate considering the patient's respiratory mechanics. Respiratory mechanics meaning compliance and resistance. And it also factors in the patient's effort. So compliance, resistance, and effort. The patient will never be apneic. So even if your patient is needing very little support from the ventilator, if their respiratory effort begins to decrease, the patient will still never be apneic. The ventilator will always be ventilating for that patient, depending on the patient's compliance, resistance, and effort. So, target minute volume. How is a percentage even applicable to this target? So, before you set this patient up, before anything, you need to know the patient's height in inches, centimeters if you're in the metric system, and the patient's gender. So, for an example, let's take a male patient 65 inches in height. Target minute volume is based on the patient's ideal body weight and the percentage of that volume. So, at 100% minute volume, you are setting the patient's target minute volume based off of that patient's ideal body weight. So, ASV sets a default target minute volume of 100%. That's 100, that's your minute volume. So this equals to a normal minute ventilation of 100 mLs per kilogram per minute in adults up to 300 mLs per. Yes, you can set ASV as high as 200+%. But this is how you control that minute volume target. Increasing the percentage of minute volume will increase your minute volume target. Decreasing your percentage of minute volume will decrease your minute volume target. But as far as how we set patients up, 100% default setting is usually what we set these patients up to start off with. And based off of our ABGs, our initial ABGs that we get after they've been on 100% for a while, then we make adjustments from there. So looking at the math, and one thing about ASV, you will not have to do this math on every single patient. As long as you enter in the patient's height and gender into the vent, it will automatically make these calculations for you. So just as to how it makes that calculation, we look at 100 mLs times 60 kilograms is going to give you about 6,000 mLs or 6 liters per minute volume. So for that particular patient, male patient at 65 inches in height, their target minute volume is 100% is 6 liters per minute because his ideal body weight is 60 kilograms. So that is how the vet will calculate that for your patient. So it's very important that you have the patient's height and gender as well. So that way you can get an accurate minute volume for that patient. So let's look at ASV in passive patients. So passive patients, passive meaning patient has very little respiratory effort. Either it could be due to mental status, could be due to sedation and paralytics. So this patient is completely dependent on the ventilator at this point. So in passive patients, ASV is considered a volume-targeted, pressure-controlled mode with automatic adjustment of inspiratory pressure, respiratory rate, and inspiratory and expiratory time ratio. So in the controls menu, you will get this window pop up. So here you're still setting your flow trigger or pressure trigger, whatever trigger is going to be beneficial for that patient. And it will usually default to 5 liters per minute. As far as ASV and auto triggering, your patient still has the possibility of auto triggering the vent. So you definitely want to make sure that you have your trigger set appropriately for the sensitivity for that particular patient. Now you are also setting your ASV pressure limit, which by our protocol we set at 30. So we do not want these patients exceeding plateau pressures above 30. So that is what makes this mode lung protective in that aspect. So the tidal volume, as far as maximum tidal volume, is controlled based off of the patient's compliance and the set pressure limit in the safety window. So if the patient has a high percentage of minute volume set, and I'm just going to throw in an example here, we need to ventilate this patient. The patient may be acidotic. They may require a higher target minute volume. So that may require bigger volumes typically in patients. But if you have a patient with very poor lung compliance, such as an ARDS patient, if they're meeting that pressure limit of 30, that volume is going to go ahead and automatically get limited. The vent is going to adjust to that limitation and increase the patient's respiratory rate, and also can decrease the patient's respiratory rate. So it is going to be a protective mode of ventilation, and it will limit the tidal volume if the patient is reaching that pressure limit. So, and also the expiratory time sensitivity percentage, it will automatically default to 25. But you also want to make sure that that is set appropriately to prevent hyperinflation. Usually 25% is a good place to start, and then increase it and decrease it as needed. So ASV in active patients. So active being that the patient is awake, can be awake and alert, or has a respiratory effort. So the patient is triggering the ventilator. So in spontaneous breathing patients, ASV is a volume targeted pressure support mode with automatic adjustment of pressure support to achieve the ASV target for that tidal volume. Basically what that means is the pressure support is going to get adjusted according to that patient's needs to reach that target minute volume. If the vent begins to sense that they're not taking bigger volumes in and they're not quite able to reach that target that we have set, that target minute volume, then the pressure support can actually increase, or what we call the driving pressure, can also increase to help that patient take bigger volumes in. So it's going to automatically adjust for that patient. The automatic decrease of pressure support when the patients recover their inspiratory strength is very beneficial to weaning. And a little bit later on in the slides, we're going to talk about ASV weaning. And it can be used to perform a weaning trial before extubation. Now, here at Mercy, we are not using ASV for spontaneous breathing trial. Like I said, you can use ASV as a spontaneous breathing trial, but for our protocols and the way we practice here, we can use ASV as a tool to see if that patient's ready for a spontaneous breathing trial. But we're not going to run a spontaneous breathing trial in ASV. That requires decreasing your minute volume target very, very low to almost 20%, for a minute volume target of 1.7, and we're not going to be performing that here, but that is something that you can do in this mode. When we're doing SBTs here, we're putting the patient in pressure support mode, or spontaneous in this case, in order to facilitate that spontaneous breathing trial. So one of the things I'm pointing out here is the vent status monitor panel that you are going to see typically on the Hamilton G5 and the C6. And as you can see here in these light colored areas, if these bars are down here in these light colored areas, that means that the patient is within parameters for a spontaneous breathing trial, meaning Their FiO2 is down to a level below 40%. And I know it's probably a little bit hard to see here. Their PEEP levels are lower. They're not requiring a lot of PEEP, below 8. Expiratory minute volume. Now this is spontaneous as well as set by the ventilator. Your peak inspiratory pressure, that's an inspiratory pressure that's actually being delivered to the patient, so that pressure support being below 8, and as well as your RSBI measurement and your effort percentage. When all of these bars are within this parameter, you will begin to see a countdown clock here. So if I have a patient that's in ASV and I'm seeing this countdown clock here, then I know that the patient is requiring very little support from the vent. They could be waking up from anesthesia, could be possibly ready to progress to a spontaneous breathing trial. So that's a good tool to use when you're in ASV. So let's look at setting ASV real quick. So this is kind of an older software version of one of the simulators, and one of the things that it is missing in this panel is the pressure limit, but you will have a pressure limit option to set here, and most vents that I have seen will either default to 25 or 30 centimeters of water pressure. So looking at this control here, you have your three main controls, which is your percentage of minute volume, your PEEP, and your oxygen. You also have your trigger, you have your expiratory time sensitivity, or expiratory trigger sensitivity, and as well as your ramp, should you need to set that. So, and the first thing we're going to set, like I said in the beginning, is your patient's height and gender. The ventilator will then calculate the patient's ideal body weight for you. You're not going to have to do the math, but it will do it for you automatically. So the next thing is the vent's going to determine the target minute volume based off the selected percentage of normal minute volume, and it will always default to 100%. So in this particular patient, at 100% of their minute volume, their ideal body weight is 75 kilos. So at 100% minute volume, their minute volume target is 7.5 liters per minute. So, and you're also going to have a couple other numbers that are going to appear here after the patient's been ventilated for about 30 seconds or more. You're going to see what is being delivered to the patient for controlled breaths. So you're going to see the respiratory rate, your inspiratory time, your expiratory time AU ratio, and you will also see your controlled tidal volume that's going to be delivered to the patient as well. So all of that data is going to appear here, and you're going to see it change according to the patient's mechanics and their effort. So if the patient has a high effort, you may see these numbers bounce around quite a bit. Okay, and the next thing that you're going to set is your oxygenation controls, being your PEEP and your FiO2 setting for appropriate oxygenation for that patient. Then you will set the controls for synchronization and lung protection, setting the values for pressure ramp, trigger, expiratory trigger, and maximum pressure limit. So let's look at our ASV monitoring screen that you have the option of setting on the G5 and the C6, and you're also going to see it appear on the T1 and the MR1 as well. What this is a monitoring graph that's going to give you a visualization as to what ASV is doing for your patient, where their effort is as opposed to where their target is. So let's look at the graph here for a second. So as you can see here is our horizontal axis, which you're going to see your respiratory rate, and then you have your vertical axis for tidal volume. Here you have your minute volume curve. So depending on what your patient is doing as opposed to the target is going to move on this curve. So if my target minute volume, as you can see here, it's set for 7.2 liters per minute, at any point on this curve, the patient is going to be getting that target minute volume. So as you can see, tidal volume can vary, respiratory rate can vary. If you have a patient with very low lung compliance, you will tend to see the patient's target a little bit lower on this curve. Why? Because their tidal volume is going to be a little bit smaller, and their respiratory rate could potentially be higher. If you have a patient with very high lung compliance, you could see it a little bit higher on this curve as well. So, as you can see this box here, this is the safety frame that is defined by the lung protective rules. So, in this box, this patient, your patient, it can breathe anywhere in this target box here, and they are in what we consider lung protective ventilation. So if you have a patient that is active / maybe passive or completely active, you are going to see them, that's what this plus sign is here. This is the patient's effort here. So that's the current patient value. And then you have your target point, which is going to move on your minute volume curve. So you could see this plus sign anywhere in this box. That still tells you that this patient is getting ventilated within this target, but they may be meeting or exceeding it here in this box, but they are still remaining lung protective. So if you have a target minute volume that is set for this patient at 7.2, and you have an active patient that began breathing above that, they could breathe above that target volume, that target minute volume you have set. So you may see them breathing bigger volumes, maybe a higher respiratory rate, or a little bit lower respiratory rate and higher tidal volumes. It all depends on the patient's mechanics and effort. And some more information that you're given on the screen is the inspiratory pressure, and it will tell you what that inspiratory pressure is breath by breath, as well as controlled breaths compared to the spontaneous breaths. So this gives you all of the information that you need as far as managing your patient on ASV. So this is very handy to have when you have a patient that is in ASV mode. Okay, so let's talk a little bit about ABG manipulation. So since we have taken tidal volume and respiratory rate out of our control essentially and given it to the patient, how do we manipulate our minute volume for ABG manipulation, whether it's CO2 elimination, whether it be oxygenation, whatever our goals are for that point. So in conventional ventilation, minute volume, we can manipulate it using tidal volume, respiratory rate, increase, decrease our pressure support for that patient, or that driving pressure for that patient. In ASV, just the target minute volume is set by minute volume percentage, so you only have one control. So to manipulate the CO2 in an ABG, in order to increase your target minute volume, you would increase the percentage of minute volume for that patient. So at 100% minute volume, 6 liters per minute target, to reduce CO2 by increasing the percentage. I forgot to add a Y there. So if my patient is at 100% and I need to increase that target minute volume, then I would need to increase the percentage to whatever that new target may be. So here we typically use our HAB1 equation to determine our target minute volume to reduce CO2. So looking at a couple of examples here. So let's look at an ABG real quick. So this patient, not much of a background on the patient, but we specifically want to manipulate the CO2. So we're looking at a respiratory acidosis, an acute respiratory acidosis. So this patient has a pH of 7.25, CO2 of 55, PO2 is 78, not terrible, bicarb of 22, and a base of -1, so an acute respiratory acidosis. So our ASV settings, minute volume percentage at 100% for a minute volume target of 6, people 5 and 40%. Patient's ideal body weight is 60 kilos. So looking at have and want, typically what I do is I multiply what I have and I divide by what I actually want to determine my new targets. You can do this for tidal volume, you can do this for respiratory rate. In the case of ASV, we're going to be using our minute volume. So I have a PCO2 of 55 and a minute volume target of 6, and let's say I want a PCO2 level of 40. Let's shoot for perfect. So what is my new minute volume target going to be? So I'm going to multiply my CO2, my PCO2, by my minute volume target, and I'm going to divide that by what I want, which is a PCO2 of 40. So therefore my new target minute volume is going to be 8.25 liters per minute. Now to determine that percentage, and again, As you adjust the percentage on the ventilator, it's going to increase or decrease whichever way you go, your minute volume target. But if you were to do the math, so that would give you 8.25 divided by 60 kilos is about 137% of that patient's minute volume target. So also, the vent will only increase the percentage by 5. So to get this kind of in a sweet spot, you kind of want to round up at this point, so to speak. So what I would look for is I would set the vent probably at 140% minute volume, which will probably give me about 8.3 or so. So I'm exceeding the target. I don't want to go below the target, but if I want to exceed the target a little bit, that's fine. You know, this is going to adjust that minute volume. So now, let's say our patient is completely passive. It is going to increase the tidal volume and the respiratory rate in order to reach this new target here. So you're going to see the volumes increase. You may see your respiratory rate increase. If your patient's already at that pressure limit, you may potentially see the volume increase by a small amount, but you may see your respiratory rate increase exponentially. So it just depends on what the patient is doing and as what their mechanics are at that moment. So let's look at ASV lung mechanics. As our compliance increases, volumes can be increased, the rate can be decreased. This is mostly applicable to passive patients, but it can also apply to your active/passive patients. So as your compliance decreases, you're going to see your volumes decrease, and you may potentially see your respiratory rate increase as well. Resistance. So we didn't talk about too much about resistance in the last couple of slides. But as you can see, if your resistance increases, your delta P will need to increase to deliver the volume until the pressure limit is reached. So that means your inspiratory pressure will begin to increase until you have reached that limit, which is 30. If your patient's resistance begins to increase, whether it be secretions, whether it be bronchospasm, whatnot, whatever's causing the resistance to increase, you're going to see that pressure, that inspiratory pressure, begin to increase as well in order to meet that target minute volume. It's going to increase the tidal volume. And once it reaches that point to where you're already at the pressure limit, then you are going to see the respiratory rate begin to increase in order to reach that volume. So that is how the vent works with the patient, depending on their compliance, depending on their resistance, and depending on that patient's effort. So it's a constant adjustment that the vent is already making that we don't have to constantly assess and make on these patients, especially if they're considered unstable. So now let's pivot to ASV wean. So yes, theoretically, and it has been done in several research papers, you can carry out an SBT in ASV by decreasing the PEEP to 5 and lowering your target minute volume percentage setting to reduce the pressure support that's needed. So in order to reduce that pressure support below 8. In this case here, you could see the minute volume was decreased to 1.7. So if the pressure support on the current percentage of minute volume setting is higher than 15 centimeters of water pressure, then you can lower that percentage of minute volume setting to 70% and then 25% to reduce the pressure support gradually to 5 to 8 centimeters of water pressure in order to facilitate that SBT. And again, it can be useful for patients waking up from surgery or just coming off sedation. I've used this mode very successfully in a lot of our open heart surgery patients as they're waking up from anesthesia. It wakes them up a little bit gently, you know, so that way they're beginning to have more and more control over their ventilation, as opposed to waking up on a mode such as PRVC and fighting with the ventilator. So it's more of a gentle way to transition into an SBT for that particular patient population. But here, we're not using ASV to perform spontaneous breathing trials. We're using it can be used as a tool to assess whether or not your patient is ready for that trial. And as you can see here in the vent monitor screen, all of our, let me go back here. All of our parameters are within the limits that we have set, so therefore you're going to see this countdown clock begin. So that clock can tell you how long this patient has been within these parameters. So just a kind of a quick review before we go to these simulations. So ASV has 4 easy setup steps, being putting your patient's height and gender in, setting your percentage of minute volume, your PEEP and your FiO2. It's very simplistic but also advanced at the same time. And this can be used in any patient population, can be used in ARDS patients, can be used in COPD patients, can be used in patients with proning, can be used in burn patients. It can be used in literally any patient population. If your patient is active and spontaneously breathing, if they are a long trach wean patient, the list goes on and on and on. You can use this in any patient population. Just as far as what I've seen clinically, in which case ASV may not be the best mode to use in some of our neuro patient population, depending on the patient's breathing pattern. If the breathing pattern is very erratic, it can be difficult for the vent to actually keep up with the changes in the patient's effort, and increase in effort, decrease in effort. You know, it has difficulty in trying to maintain the support for that patient in that moment. So it's not always the best mode in that particular population, but it can be used in the neuro population. You're really just going to have to pay attention to what your patient is doing and what type of breathing pattern that they're actually presenting. So a little bit of references on the slide. So we're going to go ahead and move on to the simulation portion of the presentation. So if you have any questions or anything, if you need to contact me or anything that needs clarification, here is my work email. Just send me a quick email and I can clarify some things. So, all right, moving on.